Hello, I'm Peter Lachman, Deputy Medical Director for Patient Safety from Great Ormond Street Hospital. We're here today to talk about the Great Ormond Street Hospital experience in which delegates from the forum came to visit us for a day. Can I introduce the team who are here to help explain what people learned at Great Ormond Street?
So hi, I'm Catherine Goldthorpe. I'm the Head of Quality, Safety and Transformation at Great Ormond Street Hospital.
Hi, I'm Chris Caldwell. I'm one of the Assistant Chief Nurses and I'm also Associate Director of Education.
Hi, I'm Lynette Linkson. I'm a junior doctor and I'm on a Darzi Clinical Leadership Fellow post.
Hi, Allan Goldman, Director of the Critical Care Division at GOSH.
Catherine, could you tell me what it was like organising the Experience Day? What did you want people to learn?
Well, it was really exciting for us. We knew we had people coming from all over the world, so we wanted to make it all inclusive. But the real key messages that we wanted to get home on the day were we wanted people to understand how important it was that we had good data to drive our improvement agenda. We wanted to tell them about how we've built capability in the organisation, so what training we've provided and how we've made sure that every individual in the organisation's got an opportunity to learn. But also we wanted them to understand about leadership, because without that we couldn't run the programme, so we have to have that buy-in from our executives.
Allan, you opened the conference, the day, with talking about data and the use of data in your division. Could you possibly explain what you told the delegates?
Yeah, I think we've developed sort of with an in-house outcomes team within the department, the cardiac, respiratory and critical care, real-time monitoring of data on a weekly basis, the good, the bad and the ugly. But I think what we've learned, what's key, it's all very well just having data and having graph after graph, but it's how you relate the data to the team and how the team uses the data to improve on a real-time, weekly basis. And I think that's the key. I think just data on its own is data, and that was one of our key messages, is that interaction of data and people.
What was the reaction to that message? Did you get anyone coming to talk to you about that?
Yeah, I think there's quite a lot of interest in how one does it. I think people can't envisage how you can collect that data without the infrastructure, but that's what you need to invest in if that's what you want to do.
Catherine, tell us about your data analysts.
So one of the things we've done at Great Ormond Street is brought all the data together in a place that's really easily accessible for people. So at the touch of a button at someone's desktop, they can bring up their theatre utilisation or the number of crash calls in their area or the number of infections that they've got. And that's great having it together, and we have it all in statistical process control charts. But what we need to do is then to take that to the next stage and make it more visible for people, because that only attracts some of the people. It doesn't bring everyone into the equation.
At the session that I chaired on statistical control charts, I was quite amazed how few people knew about statistical control charts. Is it well grounded in the organisation, Chris?
I think that a lot of people are frightened about data. Lots of people are frightened when you present them with a graph, but actually what we've done through investing in not just the technical skills of our team, but also the educational skills of our team, mean that our data analysts are able to present really quite complex data to people in a way which really is meaningful. And often those people leave inspired and feeling very empowered, because suddenly now they feel they can handle data in their everyday lives and use it to persuade managers and others to make changes. I'm
going to open this one to all. We distinguish between data for improvement and data for judgment. One of the questions I was asked was, do you have two teams, and how do you make sure that the data is used for improvement and not only for judgment, or is not mixed up? What have we done?
I mean, we work very closely with our performance management teams, and the idea is that a lot of the improvement work that we do helps the trust achieve the things that it needs to do. So although we keep the data separate so that it's seen as data for improvement and not for judgment, so we don't have targets on it and we don't have red, amber, green ratings, it can actually help the organisation and people get to where they want to get to anyway.
So the first key message is you need to use data, and you need to use it in the right way to engage staff.
Yes, and I'd add to that, I think it's really important that we stick to that message. If we're going to be using data for improvement, then we must always do that, and we mustn't switch to using it as a stick to beat people. So if we're saying it's about getting better, not about where you started, but it's about getting better, then if things get a little bit worse for a while, then we should use that as an opportunity to learn, not as an opportunity to criticise.
So I'm going to move on to the next topic about building leadership for improvement, because we can give as much data as you like, but you have to have leaders at all levels of the organisation. So Lynette, could you tell us about what you're doing with the trainee doctors?
So at Great Ormond Street, there's quite a unique course that we run there, which is EQUIP. So that's enabling doctors with quality improvement and patient safety. And what we're doing there is we're asking frontline staff, so the people who really know what's happening and what the problems are, to come along with their problems, and we teach them the tools and the skills to transform that into a quality improvement project with the support of all the transformation team. And I think that's what that's enabling is that we've got leadership from the top at Great Ormond Street, and now we're using leadership from the bottom, so distributive leadership that we're getting engaged in frontline staff. And what was really apparent yesterday is in some of our presentations that those junior doctors have gained not just involvement in a quality improvement project, but they've gained leadership skills, they've learnt about their organisations, and they're going to take those skills on for their future practice. So it's a really useful experience, not just for the organisation at Great Ormond Street, but also for the rest of the NHS when they move on.
So how many of them presented yesterday, actually trainee doctors?
So we had 4 trainee doctors present their projects, and of those 2 had moved on to other organisations, and during the discussions we discussed how they are going to move on and share in organisations that are not necessarily embracing quality improvement, how they're going to share those skills and teach them what they've learned and how they could implement that there. And it was really interesting to share with particularly sort of the international delegates who attended. They are trying to set up similar projects, and we could share the problems that we'd found and the barriers we've had to overcome with them to show them that it is possible, but you need to have leadership, you need to have an infrastructure, you need to have people who can teach the skills in order to develop the frontline staff.
And how many are having posters at this conference?
How many are here? I think we've got...
12.
Yeah, I think we've got about 12 here, and of those, yeah, so we've got we've had people win prizes, we've had people present nationally, internationally, people who've gone on to win funding from the Health Foundation for a Shine Award. So people have had great success through simple projects that we've been involved in.
So that is really focusing on trainee doctors. What about the rest of the staff, Allan and Chris?
So we have been building capability, as Catherine mentioned, right from the beginning of the work that we've been doing since 2007, and we have constantly adapted and changed that training to address all the different staff groups and all the specific needs as we go along. So using a quality improvement methodology in the design and delivery of our programmes. And we have managed to train many hundreds of staff through the organisation. Some of them have had very basic input, a one-day programme, or it's been integrated into some other training they've done, but others have had intensive training both in the organisation and externally, and are now leaders, real leaders in their field. So we've had a range of different approaches. We also focus not just on the technical improvement methodology skills, but also building leadership capacity, so teaching people how to communicate, motivate, build their teams and really deliver their projects.
And Allan, you were involved in building capacity in a different way by sending people out of the organisation to bring new ideas in. What did you do?
Yeah, so we, within the division, did the advanced training program in improvement and safety at Intermountain Healthcare, and persuaded our general manager to come with. So we had both myself and the general manager, the 2 leads for the unit, doing that. And then the next time round, we sent our most senior nurse and the physician in charge of the ward. And then the next time around, we persuaded the medical director to go. So we built an understanding and a commitment to improvement within the unit. So, and that's led to a lot of projects that have come out of it, a very active unit in that.
So the kind of message we're giving to delegates was that we are providing capability both at the front line and at all levels of the organisation, so that the language has changed over the last few years when we talk about improvements in quality and safety. Would you agree?
Absolutely, I agree entirely. So much so that actually that all new starters in the organisation now have that built in as part of their induction. So nobody starts in the organisation without having an understanding that this is an organisation that has a real drive for quality improvement.
So I'm just going to move to something different, because we have at Great Ormond Street the vision of zero harm, no waste, no waste. And now zero harm has become very topical, with the Prime Minister talking about zero harm, the Berwick inquiry about zero harm. Alan, you chaired the zero harm session in the morning, I did in the afternoon. What did you find people were interested about?
I think we had some good sessions. We had some good themes on some big topics: medical notes, drug errors, and early deterioration. I'd say sort of three of the big things. But these are all ongoing projects. I think one would be naive to think in a year or two you've cracked the problem. Even if you get it down 50%, you've still got a problem. So it's an ongoing journey.
Yes, I know, because originally when we put out zero harm, we had a bit of question of how can you really get to zero, but we were ahead of the game in coming to the idea of zero harm. What did the nurses think, or what did the trainee doctors think about this?
I think the whole notion of zero harm overall was much easier for the nurses to buy into, and they were early adopters on the whole in terms of, because they absolutely did not want to cause unnecessary harm to their patients. And so some of their early success with engaging people into building their knowledge base was around those nursing staff. And we had an early project called Transforming Care on Your Ward, which was really aimed at engaging ward sisters. And through that programme, we started to really have an impact on central line infections and things like hand hygiene, surgical site infection, through engaging those ward staff.
The other key message is how we engage parents and patients in quality improvement. You got any examples you want to give that we spoke about yesterday? Maybe you want to speak about the One Shine project?
Yeah, so the Shine project, so what we're trying to do is that we recognise that families spend a lot of time with their children on the wards. They see things that we don't see as clinicians and as ward staff, and they're an untapped resource. So what we're trying to do in this project is give them an opportunity to share the knowledge that they have, because it's just sitting there. They see things that we don't see. So we're asking them to feed back to us any concerns that they have, anything they could see that maybe something that was harm or nearly was harm, so that we can use that to then make improvements and change our practice. And we've just started the project, and we've had some really good responses. All the parents that we've approached have been really keen to be involved. They're all happy to try and improve the care for their children and for the future patients.
I guess if I could add, I think right from the beginning we've engaged parents and young people in our work, and we had parents on our transformation board right from the beginning, and they've stayed with us. And even yesterday, one of the sessions in the afternoon was chaired by one of our parents, and there were a number of members of our Board of Governors there for the whole day, including young people who are very engaged in the work that we're doing.
How do you engage them, Catherine? Because that's a key. People ask me at the end, they said, how do you get the parents involved? And the patients.
People are quite enthusiastic to get involved, actually. We certainly, I mean, you know, you only had to look at the experience day yesterday to see the amount of there were parents there who'd come in their own time just to see what we were doing. And we've never had any problem, really, getting parents and patients who are interested in getting involved. It's quite a challenge then to work with them through the projects, because obviously they have their own commitments, and there are meetings to attend, and we have to fit in around them as well. But the input that they give is so valuable. It changes the dynamic of the project completely. So it's just really worth investing that extra time and effort to get them involved from the beginning.
So I want to move on to one of our last things that we really ended off with, Alan, on how we learn from others, both within the NHS, within in the medical and health community, as well as elsewhere. Do you want to summarise what that last closing address was about?
I might put the question back to you, sort of what you felt we learned from other healthcare organisations.
Well,
and I'll then go on to the other bit.
I'll do this first part then. The key thing about it is that when you come to a forum like this, you meet with a lot of people And what I wanted to do at Great Ormond Street was to learn from the best. So we partnered first with IHI, bringing Don Berwick out and Jim Conway very early on to help kickstart the program. So we had a high-profile people coming out in the first year to kickstart it and to really focus what we wanted to do. We then looked across healthcare providers internationally and found Cincinnati Children as the really exemplar in pediatrics. And we linked up with them, had a formal partnership of 4 years in which Uma Kadagal came out to help coach us and really be our critical friend and have visits in between the two countries, our staff going there, their staff coming to us, to learn. I think that was really sped us along. We also looked at Intermountain, at Dartmouth, at NHS Institute. We sent teams to the Leadership in Patient Safety group. We really involved ourselves as far as we could to bring in ideas from healthcare and seeing who was doing the best. And then, of course, we looked at other industries.
Yeah. So we started that program. We were looking outside of medicine to really go a stepwise change in understanding risk and dealing with that. And we started off working with a Formula One team, looking at the analogy of a pit stop to a handover of patients from a theatre team to an ICU. We then looked working with air traffic control at Heathrow, looking at how we hand over the hospital from a day to night shift, the shift work. We worked with some of the gyms, the Nuffield gym, on a cystic fibrosis project called the Frequent Flyer program to take the training to patients, which had a dramatic effect on reducing the need for IV antibiotics. And then we actually set up an event called Risky Business Learning from Others, which in fact the BMJ are big partners with, of hearing from where we can get learning outside medicine.
People couldn't believe that we were able to integrate all this learning into a program and translate it into healthcare situations. You want to comment how you found that in the front line?
I think what we haven't done is we haven't stopped people doing what they wanted to do. So when people felt the desire to engage with quality improvement because they had a particular issue that they wanted to address, we didn't say, no, we've got 5 organisation level projects, you've got to fit into one of those. We said, okay, let's have a look at what you're doing, and we tried to work with them and build on their idea and then engage them with the wider projects. But that's not to say we didn't have those top level projects as well, but we felt that actually that top down and bottom up approach working together was a way to try to coordinate what could be a very messy experience.
And before I wrap it up, what are the final messages you want to give from yesterday? What was our experience? What did we learn and what did others learn? Anyone wish to comment on that from your sessions?
I found it an absolutely inspiring experience. I felt very proud of our staff, and it was a brilliant opportunity for them to see other people recognising the work that they'd done. Sometimes I think when you're doing improvement work, it can be quite relentless. Small tests of change take their toll on you and you don't necessarily notice the change, but when you have people saying, this is amazing, you're doing so much work, you could see people walking away standing a bit taller and feeling a bit happier about their work. It was a real joy to see.
We had about 50 people present yesterday, and they are all individually leading projects in improvement, and I just think that's fantastic for them to be able to show that off and to share that.
And many of them are quite junior in the organisation. They're not the directors, they're not the senior consultants, they are ward clerks and medical secretaries and nurses working on wards, as well as some of the specialists.
I think, sorry, Lynette, do you carry on?
I think the thing that struck me was that the importance of shared learning, which is quite a shift, I think, particularly for doctors and a tradition of research, and that actually for those people who are trying to start up and they're on the beginning of a quality improvement journey, they could see that things are achievable and you can get there and you can overcome those barriers, and it was just great to make those connections and be able to share and inspire others. I thought that was really useful.
My final sort of reflection, by doing the day, in a way, it makes you stop and reflect on all the things that we've done as an organisation, and I think in particular to all of you, because I've been involved at the periphery, I think it's very satisfying and a great job to reflect on years of work and try and sum it up into a day and see the reward. So well done to all of you, I'd say.
So just let me sum it up. When I spoke about this being a celebration of what we have achieved and a reflection of what we've achieved and what we haven't, and where we have to go in the future, because this is a journey that we started and it's never going to end. We're always going to continue to improve. And really, I think we're leading the way. So I was incredibly proud of what we've done. I just summed there are 5 or 6 things that we do. We have a theory of what we do. We use profound knowledge that leads into, which is from Deming, but leads into all the different methodologies we can need, whether it's lean methodology or model for improvement or TQM, which all comes from the same source. And we stick to that. We have a vision, and we know where we want to go. And we also then are building on the capability of our staff at all levels. And we've engaged nurses, doctors, and all different kinds of people in our improvement projects. And more importantly, we have the parents and the children involved in improving the healthcare. And finally, we use data to build it on. I think that's really the message we can give to the others who attended. Thanks very much.
Thank you.